have their dicky table? Make sure that you have your dicky table. You're able to look at it. So we talked about the estrogenic activity and um, or estrogenic sensitivity. On the chart, it says estrogenic activity. What I wanted to clarify when looking at this, the amount of estrogen in that pill, contraceptive, what have you. Also, y'all, make sure that you don't have on headphones, earplugs, all of that stuff while anybody ever is up here lecturing. Whenever they walk through, you shouldn't have that because everybody takes time to prepare. I know y'all are also preparing for other exams and everything as well, but please don't do that. Okay? So when you look at this, the micrograms that is in one of these pills, you see does not reflect the estrogenic activity. So they're not the same thing. The estrogenic activity is saying, does it have properties that act how estrogen does? Okay, so estrogenic activity, progestational activity, androgenic activity, that is not saying that that is how much is actually in that pill. So if you look at the 20 microgram estrogen, for instance, right, you don't see that over here for your estrogenic activity that all of these say 20. It varies. Same thing if you go up to 50. You don't see that that all of these that are 50 micrograms have 50 for the estrogenic activity. Okay, so please don't confuse those two things. Exam purposes, if you see whichever type of sensitivity, make sure that you look at the correlating columns on your Dickey table to say what has the lowest estrogenic activity because my patient has estrogen sensitivity. So just go down the column and find the thing with the lowest number. When we talk about some of these other sensitivities, you're going to do the same exact thing. Okay, so we're going to keep going through so you know how to do this. So when I look at my progestin sensitivity with this, kind of think of being like sad and in Eeyore, right, from Winnie the Pooh. So that's why I have my little donkey there. So excessive weight, increased appetite, right? If my appetite is increasing, you should see some weight. They have weight gain. You have bloating. They're just kind of tired and just going through the motions. If you see people who have preeclampsia or those varicose veins, these are your patients who are more progestin sensitive, okay? You can also see some people who present with PMS or premenstrual syndrome. With this, they have that edema, bloating, headaches, things like that, mood changes. Usually they're sad around the time that they're going to start their cycle. So in this situation, ta-da, low progestational activity, okay? So you would go down the column in your progestational activity column, and you would look and find something that has a low level of progestational activity. Bless you. So if you look at some of these things, your orthotricycline low, things like that, you'll see that these have low levels. So your orthotricycline low, some of these are on the back page. So if you turn to page 2, you'll see it under the multiphasic 25 microgram estrogen. You can see orthotricycline low there. Okay, so you see the progestational activity is just low. That is what you're doing. Again, you don't have to remember the examples. You can if you want, but it is going to be telling based off of the chart. All right. Now, looking at your androgenic sensitivity. So when we think about this, your androgenic activity is based off of the generation of progestin that you are using. So whatever is in that combined oral contraceptive, again, whichever progestin you use, that is going to determine the type of androgenic activity that is present. So when I look at this, I think about different sex hormones that can cause the oily skin, the irregular cycle. So all of these things, extra hair, right? Excess hair, mild to moderate acne that's happening. What I would want to do here is choose something that has high progestational activity. So that is your second column. And then something that has low androgenic activity. So now I'm looking at 2 columns to pick something that has a high level of progestin and low level of androgen. Okay? So high progestational, low androgenic. This is the one that's a little bit more difficult for people to remember because there's 2 things that we have to kind of balance, right? So high progestin, low androgenic. And then you see your examples listed there. Specifically when you look at Yaz and Yasmin, those have an FDA approved indication like you saw previously for acne. So not necessarily using it mainly for contraception purposes, but more for acne purposes before we put somebody on an antibiotic or some of our other meds that we can use for acne. Then if you have someone who has severe acne, now what you're doing is you're trying to pick a level of high estrogenic activity and almost no androgenic activity. So we're definitely trying to stay away from the androgen portion of it, okay? So when you look at this in your severe, the increase in estrogen that we get when we select a high estrogenic activity pill reduces the amount of testosterone that the body is making. And that testosterone could be also contributing to the sebum production that they have, which is resulting in the acne for that patient. So therefore, we try to raise the level of estrogen to kind of balance out or decrease the amount of testosterone that's being present. It also increases the sex hormone binding globulin, which binds the free T, so the free testosterone. So if I increase my sex hormone binding globulin, I can, again, get a lot of that free testosterone that's causing my acne out of circulation. Okay, so that can, again, help decrease the amount of acne that patient has. So that's why we are picking high estrogenic activity and almost no androgenic activity, because the androgenic activity is what we're trying to avoid if we can. So the only time you're looking at high estrogen, almost no androgenic, is when we're talking about severe acne. Regular, mild, moderate acne, all these other issues at the top are going to be high progestin, low, almost, none, but low androgenic, okay? When I get to severe, that's where I'm trying to completely avoid it, or you're going to see one of those very, very small numbers for our androgenic activity, okay? So again, your chart, you would go down both. So I would just practice or try to mimic in your head when you're looking at your androgenic, remembering when you're picking high progestational versus high estrogenic. And on both of these, you're trying to get as low of amount as androgen as you possibly can. Okay, so that's where people kind of get messed up and confused on this one. All right, our POPs, or our progestin only pills. When we look at these, they only have the progestin component. When we looked at these, we talked about them inhibiting that LH release, which then could decrease the amount of androgen that is being produced for your patient. Again, there's no estrogen in here. So this is for those patients who we talked about that were high risk, that had a lot of those cardiovascular issues, the side effects that we would particularly see in our patients who were using higher levels of estrogen. With that, I wanted to make sure that you all understand when we say a migraine versus a migraine with aura, a migraine is a regular migraine. They don't have the aura that's associated with it, where their vision blurs, all of the things. If they have aura, that is where we are more concerned, because they're at the increased risk for more dramatic side effects, stroke, all of those things. So on the exam, if you see with aura, that is what you're paying attention to versus somebody having a migraine with not having aura. Sorry, it was a question, and I remembered that I needed to tell you guys that. Do you want me to flip back several slides so y'all can see? Let me just show you. Sorry. Y'all no, but let me show you. Okay, so here, how we said migraine with aura. We'll learn about migraines. So you can have a regular migraine without aura, or you can have a migraine with aura. Remember that the one with aura is where you are worried about estrogen. If it's just a migraine, you're not really worried about that. Because if you look here in your estrogen sensitivity, they might have issues with migraines. But this doesn't say with aura. If this said with aura, now I'm trying to put that patient potentially on a POP or some type of progesterone only mark, okay? So that is what I mean by aura or without aura. I will tell you that. Okay, looking at this, we also call POPs mini pill, but POPs just sounds cooler. Looking at your 28-day pack, all days in a POP are active pills, okay? So must take one every day for 4 weeks. All 28 pills are active. They all have hormone in them. There's no placebo pill. There's no week off. Now, when you look at this, what is very important about this is that it has to be taken within that same 3-hour window. If they are outside of that 3-hour window, they are now required to use a backup method. They are also not our preference because they're not as good with preventing contraception as our combined oral contraceptives. Okay, so they're not as effective, less effective than my combined oral contraceptives. Okay, so this is why this will always be second line unless there is some type of high risk indication, the diabetes for over 20 years, all of those things, the stroke risk, those are the ones where they will end up over here. Other than that, we don't usually put anyone over here. Lactation, right? They're breastfeeding, that's when we will put them on these. Okay? Looking at our ideal population, you see here, again, make sure that you put migraine with aura on there. They can't tolerate estrogens for whatever reason. Some people may tell you that they don't want estrogen. Even if you try to decrease the level of estrogen, some people will still be sensitive to them. And so that just means that they can't tolerate them. You can put them on a pop. They have any type of cardiovascular risk, again, they'll be over here. So this is essentially, once you look at that high risk group, or if you look at this, these are the big things that I was worried about as to why we would go to a pop, which we know is less effective. Mechanism of action, the same thing as we talked about before, creating that hostile environment for the sperm to not be able to survive, or make it very difficult to survive. And then you see the suppressing ovulation is why we say it's not as effective. Kind of hit or miss. Also have that small window of only 3 hours before you have to use a backup method or you lose that efficacy in the pop. Okay, so not a very good option for us to use. When we're looking at our methods in which they can start them, very similar to what we already talked about before. So you have your quick start and you have your first or your same day start. Because there's no time off anyway of the pill, that's why you don't see the Sunday start there, right? Because the other one we had a Sunday start also. So when you're looking at your quick start, bless you, you see that you can start on the first day of whenever their menstrual cycle is, and they need to use a backup method for 48 hours, not the same 7 days that we talked about with our combined oral contraceptives. And then with your first or same day start, this is on the same day that their period started, and then again, no backup method is needed. So this is different from your combined oral contraceptives in the fact that there's no Sunday start here, and you also see that it's 2 days instead of 7 days, okay, as far as when how long your backup method needs to be. Your missed doses, what you can see, again, because we don't have any hormone-free days, is that if you have a missed dose, you can take it immediately, but then they need to be on that backup method, especially if they were outside of that 3 hours, okay? So before we were talking about with our combined oral contraceptives, we were saying that they had 2 days, right, that they could potentially miss, and they just need to take that one extra pill. Here, they only have 3 hours, okay? Or they have now increased the risk of the contraceptive. So again, this is why we don't love to use these first. When we're looking at our progestin excess, again, same things that you saw before. So we're decreasing that progestin content. I want you to pay attention to what you're going to do on the main slide more so than this slide, okay? Where it was saying, okay, increase estrogen here. If it's severe acne versus find something that has high progestational, I want you to focus on that more because it has the Dickey table. This is just a general thing if you didn't have the Dickey table, okay? And this, if y'all want to keep them, you can. You have to buy his whole book to get this. It's not online in a lot of places, so just something for you to hang on to if you wanted to keep it. The deficiency, you can see that they can have the dysmenorrhea. You can also, again, use those NSAIDs for that. You can give them that extended cycle. They will probably already likely be on one of these that is essentially an extended cycle if you think about it, right? Because there's no placebo days. And then you also see where they can have that late cycle breakthrough, right? So this is now happening more so at the end. When we were looking at our estrogen deficiency, it was in the beginning, the first 2 weeks. So the way I kind of think about this, and I'm not going to put 14 days, and that's why I'm saying it to you this way. So first 2 weeks are early, the first half of that month if they have breakthrough bleeding or early cycle bleeding, that is going to be estrogen, early cycle estrogen. And if it is late, then it is progestin. So after that 2 weeks, if they're having bleeding, then that means that they may not have enough progestin in the pill. So you go to your Dickey table, you'll look and you'll try to increase that level for them so that they can now be more managed and even kill with their progestin levels. When we're looking at our advantages and our disadvantages, Um, the only thing I want you to look at is what is bold and underlined, okay, on your disadvantage. On your disadvantage, make sure that you understand what I have said several times, that your patient may ovulate, and that is why we don't like them. That is why they are not as effective. Um, if somebody is ovulating, then that may mean that they could potentially get pregnant even though they are on a contraceptive. If that is the main reason why they are using this, that is a big problem for them, okay? So pay attention to this disadvantage. Everything else we've kind of hit on before. So don't worry about any of those, okay? Just they may ovulate, not as effective. This is a chart looking at all of the different progestins that we have. There's several different generations, first gen, second gen, third gen, and fourth gen of your progestins that are available. You do need to know which ones go into which generation, okay? They look very familiar. You see that a lot of them say nor something, so norethindrone and then a different salt. So just as long as you remember norethindrone, that's good enough. I'm not gonna like make you remember the difference of a minimal change that happens in the activity. So norethindrone and ethinyl is your first gen, norgestrel and levonorgestrel second gen, norgestimate and desogestrel third gen, and your dosperinone and your dienogest. These are some newer ones that are the least potent that we have. So therefore, we get a lot of our anti-mineralocorticoid and anti-androgen effects. We'll talk about these again. We kind of hit on it a little bit when we talk about spironolactone. And when we talk about spironolactone again, you'll see this come up again. So what I did was kind of put some of the things that you'll typically see with this type of activity. So spotting, they have issues like headaches, their mood disorders occurring, increased coagulation. This, your progestin activity, is a precursor to your estrogen and progestin. So when you look at this, weight, bloating, mood, spotting, again, this one was the one that was late. This is the earlier spotting. And then when you look at your androgen, I think of your androgen activity as like those sex hormones. So you can see the hirsutism, acne, different lipid dysregulation occurring, bloating type things that we're worried about, okay? So whenever you're going through this chart or table and the next table are essentially saying the same exact things. When we think about what we typically use the most, we typically use our second generation, probably a little bit more, bless you, than a lot of these other ones. These are the ones that are more prevalent in our combined oral contraceptives. The third generation, usually you'll see these used by themselves a lot as our POPs, but still used as well. And then, what else do I need you to know from here? I think that's it. So when you're going through this, see that you have higher estrogen, progestin, not very high androgen activity, but you have some androgenic activity in your first gen. You see that you don't have a lot of estrogenic activity whenever you're looking at your second gen. So that's why typically with this one, we use this a lot more in our combined oral contraceptives because we're gonna get some estrogenic activity from the estrogen component anyway. You see that it's bringing in a lot of that progestin activity, right? And more of your androgen activity. And your third gen, again, your estrogen is negligible, right? But you see, again, I have a lot of progestin activity, not a lot of androgenic activity here. And then my fourth gen, kind of, it's just there, right? Not super potent anywhere. You do get some progestational activity, but not a whole lot. Hit or miss depending on the patient. So this, again, when we talk about it, we're going to talk about it more so in our anti-mineralocorticoid capacity. So just understand this is the least potent. This is something that is good if somebody is experiencing like the acne, right? They're very sensitive because the higher the level of androgen that I have, you can see where I have more issues with that. So this can come into play for some of those patients. This is, again, a chart summarizing the pluses that you saw on the previous slide. So again, telling you in words, when you look at your fourth generation, again, the one that's least potent, make sure that if a patient comes in and they're complaining of like bloating, all of these androgenic issues that we're talking about, acne, things like that, if they're coming in presenting that way, or we're worried about those cardiovascular risks, because it has no estrogen activity essentially, and because I'm also being able to tap into the lack of androgenic activity, this is a good option for those patients. So bloating, water retention, hirsutism, acne, increased cardiovascular risk, fourth gen are good options because of the lack of potency that they have. All right, so this is specifically talking about what I just said. This is our fourth gen that we had. Typically, we're looking at our drospirenone, and when we talk about spironolactone, it's also kind of going to fall into that same category, and so that's why we see that anti-mineral corticoid effect, which decreases the bloating that patient may experience. And this will make sense again whenever we kind of go over some of our corticosteroids. You see the low androgenic activity, so with that, low to no. So with that, you see the benefits in all of those patients who are experiencing these side effects. Your interactions, because it can potentially increase potassium because it's an anti-mineral corticoid drug, it has those effects. What you can see is an increase, again, in that happening with other drugs that do the same thing, that increase potassium. So I have NSAIDs, heparin, ACE inhibitors, potassium-sparing diuretics. A lot of these you're going to talk about in the third block. But when I look at these medications, they all can potentially increase the level of potassium as well. So now I have additive effects. This is very important for you to remember these interactions, because this is something that a patient could easily be on, right? Taking an NSAID, taking something for high blood pressure, which is that ACE inhibitor, taking one of those medications and being on a contraceptive or being on something that has that progestin in it. Even if they're on a POP or a combined oral contraceptive, they still are going to be exposed to this progestin. Here are our different products that we have that are clearly combined oral contraceptives, because you see your estrogen component here, and then you see your combination with your drospirenone. So like we said, Yaz and Yasmin had that acne FDA approval. That's why, because it's a fourth gen, so therefore I don't have a lot of that androgenic activity to where I will experience acne, hirsutism, the lipid dysregulation that they may experience, the bloating, okay? So now linking those together can make a little bit more sense. Recently, they have created a POP that patients can go and buy without you prescribing it. All other contraceptives are prescribed. But now, if you go into like Costco or Sam's and you look at the shelf, you can see a POP. Why they chose to do a POP over estrogens, I think, is because it has a safer side effect profile. But if I'm trying to use this for contraceptive purposes and nobody tells me that I only have 3 hours to miss with taking something, might not be the best option. Maybe we shouldn't put it over the counter. I'm all for access. I like the access of it. It's just kind of like benefit outweighing the risk of what's better to do. So at least people have something. It's more affordable. Like if I can't afford to get to the doctor and pay for my contraceptive, right? You have to go to the mic. If sorry, we're laughing. Somebody had a question, but they didn't want to go to the mic. Remember, go to the mic if you have a question, so that both of you guys can hear it. But the thing with this is that if it is beneficial for patients who would have a barrier to wanting to have contraceptives, right? If I don't have insurance, now I'm worrying about paying for the doctor's visit. And then not only do I have to pay for the doctor's visit, but now I have to pay for whatever they prescribe me. I have to pay for the contraceptive. This allows them to just go into the pharmacy and buy it without anyone, without a prescription, any of that, okay? So this is your over-the-counter O-pill, which is a POP, the first one that's approved. And again, it's just the progestin, so your norgestrel is the only thing that's added. Very effective if they use it within that 3-hour window. As soon as they are out of that 3-hour window, just watch this plummet, okay? All right, everybody was asking, well, what are the adverse effects? We're gonna talk about the adverse effects. Here are the adverse effects, okay? There's a lot of adverse effects. Contraceptives are great. Most of the adverse effects that people are going to experience when you initially put them on a contraceptive is going to happen within that first 3 months. Usually 3 months would be 3 cycles, right? So within that first 3 months. If I come in and I'm complaining to you, I'm having breakthrough bleeding, and you're like, I've only had you on this for a month and a half. Hang in there, okay? I have to wait until 3 months or 3 cycles for you to see if this is going to work for me. And seriously, magically, sometimes the symptoms will just disappear after that 3 months, if it is a good contraceptive for that woman that you put on it. If it is not, and they're still experiencing the breakthrough, that's when you rely on all of the other things that we talked about, and you may have to switch them to another contraceptive. Sometimes women will trial, I don't know, sometimes 3, 4, 5. I think I was at like 7. So it depends, right? So during this time, you can experience breakthrough bleeding. You can experience hot flashes. You can experience all of the things, right? And I was like, at that time, I was maybe 18. So I was like, I know it's not menopause, I hope, right? So you have, I hope not, but you have to understand that sometimes these things are, yes, hold on, and they can hold on for 3 months, and you still have to switch them, okay? So is that discouraging for someone who's on the end as a woman who is bleeding unpredictably, like I'm out with my friends and all of a sudden now I'm bleeding through my clothes and I didn't expect it? Yes, that could be very frustrating. So your empathy is needed, okay? But you can find something that works for them, and based off of those tools in our Dickey table that we talked about, you can adjust those levels based off of what they need. They have to document their symptoms for you, because if you don't know what to fix, you're just shooting blindly trying to give them some type of contraceptive, and that's going to prolong this process, okay? So 3 months, they have to hang in there with those symptoms, and usually they will go away. And breakthrough bleeding is one of the biggest ones. Again, make sure that it's not attributed to the fact that they're not taking their pills, all right? Because that was me. You'd be like, oh, I'm bleeding again. And she's like, are you taking your pills? No. I take them every other day. She's like, well, that'll do it, all right? Remember your black box warning. This black box warning applies to anything that has estrogen, okay? We're worried about those cardiovascular events because of the estrogen component. So if I had a pop or if I had some type of LARC that does not contain estrogen, I'm not worried about this black box warning. I'm not worried about smoking my cigarettes. I can smoke in peace, okay? Looking at this, your OCP danger signs. This is your oral contraceptive danger signs that we're talking about. These are very, very important because they can be very, very serious. I only want you to know your ACE acronym. You will learn about this possible problem later. I just need you to know the side effects of what they could be experiencing. So A, abdominal pain, right? Chest pain. When you look at your headaches, again, if they're very severe now, right? Because remember, I'm worried about that because of the estrogen component. Any eye issues, whether their vision is starting to change, they feel like they can't see out of a certain eye. When you're doing their vision test, their vision has decreased, things like that. If it is coinciding when you started the contraceptive, that could be definitely serious or definitely signal things that are more serious, increase in blood pressure, things like that could potentially lead to a stroke. And then your severe leg pain, it's particularly in their calf or their thigh. Now, these are things that you are telling the patient to watch out for, okay? These are not things that they wait to go away, okay? So that the 3 months, that was just the other side effects, like, oh, I'm bloated, or oh, I feel like my mood is over the place, or oh, I'm having breakthrough bleeding. Those things we're not worried about. The aches, we are worried about because the aches could kill them or have very life-altering consequences if they occur and if we miss them, okay? So aches, this is what you would be counseling your patient on. This is what you would be telling your patient because these are things that they can catch themselves, all right? Now, your breakthrough bleeding, how are you going to look at this? We already talked about this, so increasing your estrogen and your progestin. First and foremost, make sure they're taking it, right? But increasing your estrogen and progestin depending on when that's happening. Then looking at your nausea and vomiting, that is another side effect that can happen. The higher the dose sometimes of the estrogen, the more likely they are to experience this. So the way that we get around it is we tell them to either take it at night because if you're asleep, hopefully you don't feel the nausea and vomiting, or we tell them to take it with the largest meal that they're going to have of the day. So if I eat a large lunch, what have you, take it at that point. You should be a little bit better. And then your acne or hirsutism, this is depending on if you put them on a combined oral contraceptive or a POP that has high androgenic activity, that is where you can again see this happening, right? Which is why we wanted low androgenic activity in a patient who has acne. I can also cause this to happen when I put someone on a contraceptive if those levels are too high for them, okay? So again, that's how you can find out if somebody is sensitive, because you put me on a contraceptive and now my face is going crazy. You're like, oh, okay, let me find something that has a low androgenic activity. Okay, so I go to my Dickey table and I find something that has low androgenic activity because now I see that this person is sensitive to it. Some stuff you find out after you've done it. Okay, sometimes we don't have the hints to avoid things later. And then looking at what you would do in those situations, again, because I had that decreased androgenic activity in my third and my fourth gen progestins, that is why I would like to choose one of those. So going back to your table here, because I had less androgenic activity here, this is typically why I would stay around that for my patients who have acne. My voice just went all the way away. Okay, drug interactions. So there was a myth, and people still kind of talk about it sometimes, where you don't want to use antibiotics with contraceptives because it can decrease the efficacy of a contraceptive. That only holds true for one thing, and that is going to be your rifampin. Okay, your rifampin is the only thing, and everybody is not on rifampin. Okay, so this is the only time where we were really worried about that antibiotic activity. Everything else was a myth. They haven't proven that any other antibiotics cause this to happen. Your other medications that you see, so phenobarb, phenytoin, ethosuximide, carbamazepine, look familiar, right? Our anticonvulsants were right here. A little fresh over here in this room. Y'all are still non-emotional because y'all done got through it. They're over here like, yes, we remember, okay? And then your St. John's wort. St. John's wort is a popular herbal that people use for several different things. When you do your med rec, you need to ask your patient, are you taking anything over the counter? And they're going to probably tell you no. And then you have to name off things. Oh, do you take aspirin? Oh, do you take Tylenol? Oh, yes, yes, yes. And you're like, I just asked you this and you told me no. You have to be very thorough. Oh, do you use Bengay? Some of these things have menthol and they have aspirin in some of those muscle rubs that people use, but they don't think about that. So then you can overdose them on aspirin because they're rubbing it on them, but they're also taking it by mouth. Okay, so be very thorough. Don't just take no. Ask them more questions sometimes, because this interacts with a lot of our drugs that we have. So please make sure that you're remembering these. And again, we already talked about this earlier. If I do have one of these on board, because they are an inducer, right? So my inducer is going to decrease the amount of drug that I have because it's a super factory and I'm not feeding it enough. So that's why I would say, okay, instead of staying around my 20 or less than my 35 micrograms, I can go up to my 50, and whatever is being induced, not a big deal, I'll make up for it, right? So that's why they're saying use another contraceptive method, which is preferred in my opinion. That is how I would practice because of the side effects that come with estrogen, or give them the higher dose of estrogen, okay? This is what I've already told you, so the only thing that you need to worry about is what's in bold. That's just giving you all the detail about the study and da-da-da-da, not asking you about studies. Rifampin is your only antibiotic. None of your other ones really do that. All right, lactation. We already talked about lactation a lot, and we're going to use our what? Combined oral contraceptives or a POP? Pops, pop, pop, pop. Okay? So, with your estrogen, when you use these, they're inhibiting the prolactin, and therefore you'll see a decrease in the amount of milk that is being produced. So if I deliver a child, one, you need to hold off on estrogen anyway because I am hypercoagulable. Patients who are pregnant or who have just given birth, they're in a hypercoagulable state. So now if I just gave birth and you add estrogen immediately after, you have just increased my risk of having a cardiovascular event, which we don't want to do. So we avoid estrogens anyway in this situation. But if I am saying that I want to breastfeed my kid for 5 years, not saying that, don't do that. If I wanted to, it's my right. I could breastfeed him for forever, okay? But I had a friend who actually did that. I was like, girl, if they can walk to you and do that, I don't know. I don't know. Don't embarrass me in public, because her kids would like pull her dress up. I'm like, oh my gosh. Wait until we get inside. No. But she has really, really, really smart kids. They're awesome. They're awesome girls. They're awesome girls. I love my girls. But if you give me an estrogen and I'm trying to breastfeed, you have decreased the amount of prolactin that I have, and therefore I'm not going to make as much milk. So now I can't feed my baby. I'm mad at you, okay, because I'm cheap, and now you're making me go buy formula, okay? I would like to use my boobies instead, okay? She's cheap. So that is what happens with estrogen. So be very careful with this. Even if someone is postpartum, their baby's 5 months, 6 months, even if you add this on later, after their milk has come in, when you put on this combined oral contraceptive, it will decrease that prolactin and it will decrease their milk. So it's not just about the beginning, okay, of the milk coming in, because it takes a while for milk to come in after someone has a baby. This could be they are established, they have been, in their routine, and you put on a combined oral contraceptive, and just like that, within a couple of weeks, you will see that their milk, and some people a couple of days, that their milk is starting to dry up. It's the contraceptive, okay? So they need to be on a pop. So my pop, lesser effect on lactation, and I would prefer my pop in that situation because I'm not messing with my progestin, okay? So now I can continue to make my milk, and you can give me a contraceptive. Win-win. Issue is I got to make sure that I take it, especially if you're giving me my oral, okay? So again, injectable progestins, your oral progestins, they do not have any effect. Increasing milk production, possibility, we're not going to use them for that. So just because somebody's like, hey, I'm not making enough milk, do not prescribe them a pop, okay? They need to make sure they're eating and doing all the things. But just understand, progestins are preferred when we're talking about lactation. Aw, so sad. So this is what I was just talking to you about. I know this chart looks overwhelming. If you look at the memory jog, it kind of makes it a little bit cleaner for you. I went through and rebuilt the chart again after building what the CDC had. So when you look at this, this is saying my timing postpartum. So how many days after me delivering my child can you give me a POP or a combined oral contraceptive? And then am I breastfeeding or am I not breastfeeding? Plays a role as well. So you're looking at two different things. So blanket statement, if somebody is giving birth, they want to breastfeed, you need to wait at least 6 weeks before you give them anything. This is allowing their body to produce the milk, allowing them to bond with their child. So their job is to make sure that they don't get pregnant right after they had that baby. People do it. My sister has daughters who are the same age for 3 months. I'm like, what were you doing? Okay? It is possible. But she also had one early. So that is their job because they have no coverage. So what they're using at that point is a condom, whether it's female condom, sponge, diaphragm, whatever they have to do, that is now on them for that 6 weeks because you're not giving them anything because you're trying to allow their body to make the milk, have their milk come in. After that, then I have to decide, am I doing, and when can I introduce a combined oral contraceptive potentially versus not. So if I am outside of the 21 days and I'm breastfeeding, I can potentially say, all right, I will give it to you. Do I want to? No, not ideal. I want to wait 6 weeks. But if I am stressing it and I'm like, I need something because I know myself, I'm not going to be able to wait 6 weeks. I need something now. Very minimum 21 days, okay? So if they say, yes, I'm breastfeeding, and when can I begin to use a progestin? The way to read this, if you see a 1, that means that they can use a pop. If you see a 2, that means that they can use the implant. If you see a 3, that means that they can get the depot shot. Okay, the DMPA stands for that depot shot. So all of these are okay. Your depot shot is last line because it's a high level. Remember, it's going in there and it's going throughout being released over that 3 months. Combined oral contraceptive, absolutely not, increasing the risk of them having VTEs. They're still in that hypercoagulable state, and they also may decrease their prolactin. So this is a no. Your 30 to 42 days, now we're worried about VTE risk, like a history of a VTE risk versus not having a history of VTE risk. You know what I'm going to do? We're going to go over this when we get to the memory jog, because this one, in my opinion, is more confusing, and I'm looking at y'all's faces and y'all's faces, and y'all are like, what is happening? So we will go over this whenever we get to the memory jog summary of it. Is everybody okay with that? Okay. Okay. But bottom line for this one, if I am not breastfeeding, right, you're going to at least give me some time to recover, not be in that hypercoagulable state. So if I am less than 42 days without a VTE, you can give me any of my progestins. If I am less than 42 days, but I have a VTE risk, so if I have a history of a stroke, any type of cardiovascular issues, then I can only give them a pop or that implant. Okay? And then over 42 days, I can give them a progestin or I can give them the combined oral contraceptive. It doesn't matter because I'm not breastfeeding. Okay? This one, over 21 days, they can get a combined oral contraceptive, but only if they don't have a history of VTE risk. If they have a history of VTE risk, they have to wait the 42 days. This is all of your non-breastfeeding women, okay? So we'll go over it again. We'll go over it again later because y'all is looking at me here. Okay, so this is again your breastfeeding, a summary of what's happening. So you're going to initiate the progestin, give them at least 21 days if they absolutely have to have it. The 21 days also goes into their, again, if they can wait 6 weeks, it's ideal. More of their milk will be coming in. But you also have some people who have greedy little babies. And they just came out, right? They're growing. And some of them will breastfeed more than the milk that is being produced. So you have to supplement with formula, which is fine. Okay? So if that is what they mean by, partially breastfeeding versus exclusively breastfeeding. If I am exclusively breastfeeding, that means I don't want any formula. I don't want my child to have formula. They're only going to eat off of my breast. That's it. Then you're giving them 6 weeks to build up as much milk as they can because that is their only source. Whereas this person, I can do that a little bit later and delay how that milk is coming in because I know that they're going to supplement. And some people are very, very, very sensitive about if they want their baby to have formula or not. So be mindful of that and be respectful of that and don't make that assumption for them, okay? My first kid, I was like, absolutely not, I am breastfeeding. After that, I was like, hey, what do we need to do to feed the kids? Let's feed them. I just need them to be healthy and okay. So again, you have to respect where people are. There was nothing that anybody could have told me to say, hey, you need to give your baby formula. No, I do not. Okay, so again, just be mindful of the position that you're in. Educate your people. All right. Estrogen, may consider this 6 weeks postpartum. Again, just stay away from it because it is very likely that their milk production is going to go down. I did this one time and I was like very adamant. I was like, I need my NuvaRing. I want a NuvaRing. Give me a NuvaRing. And the doctor was like, I don't think you should do it because your milk. And I was like, it's gonna be fine. I got a lot of milk. No, 3 days she had no milk. And I was like, are you kidding me? Take this thing out. I gotta feed the baby. Okay, so I was in the deep freezer using the stores. So like it is a real thing that is very likely to happen if they want to try it. That was me. I had to try it. Let me see if it happens to me. Maybe it's not gonna be me. And it was me. Very fast it was me. Okay. So then the not breastfeeding. This is again if they don't have those cardiovascular risks because my cardiovascular risk increased my VTE risk. So if I have no cardiovascular risk and I want to continue to breastfeed, you see that I can do my progestin almost immediately because there's no estrogen. So I'm not worried about increasing that risk while they're in the hypercoagulable state because there's no estrogen around. Once I introduce estrogen, combined oral contraceptives, now I need to wait a little bit longer. So that's where you see at least that 21 days, potentially that 6 weeks if they have the history of a VTE. You got to wait longer so their body can re-regulate before you add on that combined oral contraceptive. Ooh, emergency contraceptives right before the break. So, emergency contraceptives, levonorgestrel, ulipristal acetate, and copper IUD. Emergency contraceptives can be used for several different reasons. When you're looking at these, your levonorgestrel is over the counter, your ulipristal is a prescription only, and your copper IUD means that they need to have access to a healthcare provider to be able to insert the copper IUD so that it will work. Okay, so 3 different means for them to get protection. The easiest and most accessible one is, of course, the Plan B, the over-the-counter. Has several different choice brand names for this. Next Choice, they have all these things. Take Action, there's lots of them. Again, we do have these in the pharmacy, but they're only going to be able to be prescribed to somebody who is a beneficiary. So the male soldier can't come and be like, I need a Plan B for my girl. Like, well, is your girl married to you, or is she just like some girl? Because you can't just get them for some girl, right? Like, they have to be the girl, or the, so like, you gotta, I'm the girl, okay? So you have to make sure that that they have an ID card for us to be able to dispense it to them. If they are not in our system, there is nothing that we can do to give this to them. So they're going to have to go and spend their $50 or $60, whatever they are now, in the pharmacy, at Walgreens, CVS, wherever. Okay? So when you're looking at this, conception is usually going to happen around the time of ovulation. So people need to know when they ovulate if they're going to try to naturally avoid becoming pregnant and they're still having sex. So when you look at the capability of fertilization, you see that it's only about 24 to 72 hour window, okay? So people getting pregnant is very, very in a small window, 24 to 72 hours. So your mechanism of action that's happening here is that you're getting a very high level of that estrogen or progestin, depending on how we give them this, which medication they take. And that is going to try to delay the development of the follicle so that that egg doesn't become released. And therefore you can prevent the ovulation. And if I don't ovulate, there's no egg release, and therefore the sperm can't join the egg to do anything. Also, if that has potentially happened, and this is where the ethics parts come in, and we're not going to get into that into Pharm, but if the sperm and the egg have already met, so fertilization has already happened, what could potentially happen if somebody uses emergency contraceptives is that it will block the implantation, which then means that they won't have a viable pregnancy. They will then have their menstrual cycle, and then they will just like dispel, I guess, the when they're shedding the egg that is fertilized. So again, that is a personal thing on what people believe. Your job, if you don't want to do things like that, that goes to your committee at wherever you're stationed to say, do you want to prescribe contraceptives? Do you want to prescribe a emergency contraceptive? So preventing pregnancy, not terminating pregnancy, again, is that definition depending on what people believe. Some people think the sperm and the egg joining, that is pregnancy. And then some people feel like the pregnancy is because it has implanted. So that is the term as to where this is coming from, okay? Looking at who can use it. Again, when people come, don't automatically assume that they're out there doing their thing. Sometimes there are situations that happen. So your job always, and what I always tell you guys, is don't judge people who are coming in front of you, okay? Because you don't know why they're there, all right? And so you have late withdrawal, failure of that barrier method that they did try, but it didn't work. And yes, we do have some people who are out there and they didn't try to do anything, and they're like, I'm just going to get a Plan B because I know that it works, okay? In those situations, especially if they come into a pharmacy here, we do have a limit on how many people can get because this is not birth control. This is not a contraceptive. This is an emergency contraceptive, okay? So if we see too many people coming, or the same person coming in several times, we're like, hey, have you talked to your doctor about potentially getting on a contraceptive? Or, oh, guess what? You're already at the pharmacy. Here at BAMC, we have a program where we can prescribe you a contraceptive. Would you like one? Because we're not going to keep giving you a Plan B, right? So there are, again, situations. Your job is to make sure that you ask the questions to prepare your patient and to educate your patient. The longer that they take to ingest their emergency contraceptive, the efficacy goes down, all right? So they need to get there as soon as possible. So taken within 24 hours, 95% effective, 72 hours, 89% effective, again, continues to decline. Some of these have different deadlines, which we're gonna see right here. So you have your Kappa IUD. This one is almost 100%. The issue with this one is that they need who to put it in. They need a provider. They need you guys to put this in. That is going to be the barrier because you're not going to have sometimes great access to care. People are not going to be able to get into you very quickly. So almost 100% effective. They need to use it within 5 days of them experiencing whatever that unprotected encounter was, okay? When you look at your Ella, now, this is very important because a lot of people don't know this, even a lot of pharmacists don't know this. When you look at Ella, you see that this may be less effective than anyone who is less than 195 pounds, okay? So, we worry. Sorry. Over. I was, no, my bad. Over. Don't, y'all laughing over there too. Don't be laughing. I meant to say, sorry. Meant to say over. But I want to make the distinguish between these two. Your Ella and your Plan B. And this is the one that most people, again, have access to and that they take. But if somebody is over 165 pounds, that's not a lot, right? Like, it's not a lot for people. They can, thank you, because I wanted to do that too. Somebody just got hit with a stress ball over here, guys. That's what happened, okay? Um, but, but when you're looking at this, there are several people who could be taller, right? Somebody could not be overweight in a woman who is over 165 pounds. And they take the Plan B and they still end up pregnant, right? Because the efficacy could decrease based off of the different types of sex hormones that people of different weight may have. And yes, obesity can also decrease the effectiveness of these emergency contraceptives as well. So the way that you can kind of get around this is that we have to have the prescription, because now I have a larger weight limit, right? The 195 pounds. So as long as they're under 195 pounds, that's a little bit better, right? Now I have a larger window, but the issue with this is now I have to have a prescription. Again, the same thing comes into play. These have barriers. This does not have barrier. The barrier is really this limit in the 165 pounds. Once you hit over that, it's not to say that it won't work at all, but the efficacy decreases. So losing the efficacy over that weight, losing the efficacy over the 195 pounds. Again, these two you have 5 days, and this one 3 days. Okay? So smaller wiggle room, but easier access. These require more of a healthcare provider role, right? They have to have the prescription or they have to have the IUD placement, but they do have 5 days. Time is very important. The sooner, the better. This is an FYI for you guys, so you don't need to remember this, but this is just telling somebody, like, if they were in a situation and they had one of these birth controls on hand, hey, take 20 of these pills or take 4 of these. That's how high the estrogen dose is. So that's why for my patients who I see coming in all the time, who's using an emergency contraceptive that they don't need to be consistently using, I say something to them, because this is not something that you want them using all the time freely. So this is not, you don't need to tell patients this. This was for y'all to just see high levels, okay? Higher levels than what they're taking on a daily basis to suppress contraception, okay? All right, FYI this, not asking you about this, not gonna ask you how many pills somebody needs to take to not have a baby, okay? And then we'll talk about this when we come back from our break. So let's do 1405, please. He already knew. They said they're gonna have a better average than y'all over there, okay? Uh-uh. The CPA. And you have the worst schedule, you think it's worse? Well, no, they got hit like that in Pharm 1 too. That third, they did. That third and that fourth exam happened just like it happened for y'all. It happened for them. They had 4 hour days for me. Y'all had 4 hour days with me, right? No, yes, they. No, they did. They did, because what was happening sometimes is I would teach over here and leave and then have to go teach over there. I was teaching juniors and sophomores at the same time. So sometimes I would teach them twice, so for like 4 hours, and then go over there and teach for 2 hours, because I had 6 hour days. So I do remember that. I don't know what happened. I don't know. I've been here since 2022, so I have no idea. It was never like this. As far as how I teach it, I always teach it half. It never goes the whole time. Now, Pharm 1 is also Pharm 2. It's still the same length. The length hasn't changed. But I do usually teach a couple of times, because it helps you guys with the other courses that you're going to take. Like, you don't have a background of any other drugs, and you start hearing drugs and heat and stuff like that, and you don't have Like, what antibiotics? So that's what. I, I won't tell y'all the average, but I'll let y'all. I'll be like, no, no, next door might beat y'all, or that's what I'm gonna say. Okay, I'm gonna teach in the other whoever's classroom when. I'll make pound cake for everybody. I will make. That was the wager that they suggested was cake. I will make cake for everybody. I will make 4 cakes, and I might make some cookies. All right, real quick, let's finish this. The other routes. Can y'all see over there? The screen is back up. Yes. Okay. So the other routes for hormonal contraceptives. So again, we kind of went over some of this. When you're going through this, I want you to focus on what you see in bold throughout these slides, okay? Because there's a lot of information on things that I don't need you to remember because it's going to tell you the amount of estradiol in your progestin in Genesis, okay? What I need you to remember is that you have different formulations based off of what your patient would like, okay? Your efficacy is similar to the pill. Again, your issue is going to be the patient remembering that every week that they need to put on a new patch and also making sure that the patch is still wherever they put it. Sometimes people will put on the patch, especially if they have it on their butt, and if they're not looking and checking themselves out in the mirror, they don't know that their patch came off of their butt, and now you don't know how long you've been without your contraceptive. That might be a problem, right? Versus you physically seeing something, or even if you have a ring. And sometimes people will say that their ring came out as well, and they didn't know that their ring came out. So again, sometimes I tell people just check and see if it's there, okay? When people have sex, sometimes you can have where their ring can come out. Sometimes people can go swimming, they can go do things, and their patch could fall off, and they have no idea, okay? So what I say with this is you have to be vigilant if you are using something that is outside of that shot, a LARC, or your pills, because those you know that they're there, right? I know that I have my implant. I know that I have my IUD. I know that I received my shot this month, right? But if I have a patch or if I have that NuvaRing in there, that's something that's more passive for me to be able to use. If I'm not checking on it to make sure that it's still there, I don't know if it comes off or if it comes out. So less effective in women, again, weighing more than 198 pounds. We want to avoid using them. Less effective, and it also can cause more issues for them. This is a higher level of the estrogen, so on the higher end of what we would like to be at. And when you look at people who are close to being overweight or if they are obese, that increases that risk of the VTEs. And then you also see contact dermatitis, so the adhesive that some people have sensitive skin, and the adhesive to put the patch or attach the patch to their skin can sometimes cause site reactions there. So think about that anytime you look at any type of patch or adhesive that's going to go onto someone's skin. Big thing here, bold things, weight limit. I also need to make sure that it is there. Contact dermatitis, and also the increased risk of thromboembolism. When I look at where it should be placed, there are several different places. They need to make sure that wherever they do place it, it's not hairy, because if you stick something on, you got to take it off. Okay? And if there's hair there, guess what's coming off too? Your hair. The other thing with that is that now your drug is having to go through that, and you have created now less adhesiveness, which means that now that patch has less contact with the skin, which is what it's supposed to be getting absorbed through. Okay? So it needs to be in an area that is not hairy. So hopefully none of these areas that we're looking at here are hairy. If they are, tell them to shave it before they put their patch on. Make sure that they're not putting it on their breasts. We already said that this could potentially, depending on what type of contraceptive we give them, that it could increase the risk of breast cancer in some of our patients. So looking at this, making sure that they're not putting something directly on their breast, especially at this higher amount of estrogen. One patch every week for 3 weeks. Again, they have that week off, and that's where they will have their cycle. Make sure that they're only putting on one patch at a time. Some people think, oh, I need to put on 2 patches because I'm going to have extra coverage. Don't do that. We don't need extra coverage. Like, it's enough, okay? Because now you're increasing the amount of estrogen that you're exposed to. The initiation, so Sunday start, quick start, same day start, all of those are still the same initiation options that you have, and the way that you can remember that is you're administering it almost the same exact way, right? 3 weeks on, a week off. So those starts are the exact same. The only one that was different that we talked about was the POP, because again, all of those are active pills for them. Your missed doses, if that patch is off for less than 24 hours, then they can either reapply it if they know where it is, or they can put on a new patch and they don't need a backup method. So they have 24 hours. Once they hit over that 24 hours, they need to replace it with a new patch and they need to use their backup method for the 7 days, just like we talked about with our combined oral contraceptives. Cutoff time a little bit different, right? But we're actually, it's 24 hours. So, but make sure you understand 24-hour cutoff, less than 24 hours, no backup method, put on the new patch or find their same patch that came off and put it on. Over 24 hours, get a new patch, put it on, backup method for 7 days. Looking at your vaginal ring, again, make sure that they understand that they're going to put in this ring, they leave the ring in for 3 weeks, and then they take it out. On the 4th week, they're allowed to, they have their cycle. You can also do the continuous or extended cycle with this as well. On that 3rd week, instead of them taking out a ring and leaving it out, they can put in another ring. So you can give them 3 rings and that still will cover them for that 84 days. They just would skip their week off and they would still have that coverage, okay? So the same thing that we did with the pills to give them that extended cycle, we can do with our patch. We can also do with our ring. We just skip the week off. Inserting a new ring after the 4th week is a big thing. Make sure that they remember it. You don't have to remove it during intercourse. Some people will say that they do or that their partner feels it. You will hear some people also say that it comes out during intercourse. Again, if it does, make sure that they find the ring and they can rinse it off and put it back in. Some people are also more prone to having infections, vaginal infections. So I also tell people, hey, you can take this out when you're in the shower and rinse it off, okay? Doesn't hurt. You don't have to leave it in there for 3 weeks without making sure that it's there or that it's cleaned off. They don't need to use soap and water. Just rinse it off with water. They put it back in their body. They're fine. This has that 3-hour cutoff for the missed doses, which is why we sometimes don't suggest that they take it out during sex, because if I take it out and I put it on my nightstand, what if my nightstand was dirty? What if it was dusty and now I took it and I put it back in my vagina, right? Like, too many things can happen, increased risk of infection, all of the things. So just leave it alone. If it comes out, tell them to just put it back in. It's okay. It's not a big deal. All right. So 3 hours or less, rinse it off, put it back in. More than 3 hours, they need to use a backup method. They can still put it back in, but a backup method again for the 7 days. When you look at this, when you're comparing it to our oral contraceptives, so our combined oral contraceptives, you don't see an increased risk of VTE risk, and we don't see that it has reduced efficacy in our women who are obese or who have a BMI that's over 30, okay? If there's breakthrough bleeding, they can also still use a tampon while they have the NuvaRing in. When you're inserting this ring, it opens back up, right? So there's still area for them to put in a tampon and all of the things. They just need to be careful that when they remove that tampon, that the ring did not also get removed whenever they pull it out. This is that newer ring, the newer ring that I talked to you about. Similar to that combined oral contraceptive, again, a very, very low failure rate. Your administration, same thing, putting it in for 3 weeks, taking it out for the 1 week. That's whenever they're having their cycle. But what they're doing is they're using the same ring and not a new ring. So when we talked about the NuvaRing, they threw it away. They never reused the NuvaRing. When you're talking about the Annovera, they can use this one again. Okay, so this, the year-long one, you know what, I just noticed the name isn't even on here. It's on your summary slide. How'd that happen? But with this one, again, they have a little pouch that it comes with. They should rinse it off. The big thing that you need to counsel patients on, make sure that it is not wet when they put it in the pouch, because now that water is sitting there for a week until they use it again, and lots of things can grow in a week, okay? So they need to make sure that it is dry. Leave that pouch, the pouch that they have to put it in, open for a little bit so that it can dry off, and then seal it off until they're ready to use it again that following week. Again, this one is 2 hours versus the 3 hours that we had with the NuvaRing. So 2 hours, rinse it out, put it back in if it came out. If it was over the 2 hours, they need to use a backup method. And then again, that same thing, there's no VTE risk that we see over our orals, and then not enough studies to let us know if it is going to be effective in women who are over 29, who have a BMI who is over 29. As this drug kind of continues to get used, we will see more studies. Right now, there's limited information because it is a newer drug, and you will see that a lot with newer drugs. We don't have a lot of the data yet to say that it may or may not work. So sometimes they'll err on the side of cautiousness and say, okay, well, we're not sure what's going to happen once they get over 29, because we see that we don't have that efficacy as much whenever we're looking at our NuvaRing, right? So have reduced efficacy here over 30. When I'm looking at this one, I'm not sure yet because it's too new. I don't have enough data to show that or support that. When we're looking at them inserting the vaginal ring, again, this is something that you're just prescribing. They're doing this themselves. So however they feel like doing it, doesn't matter. Hanging from a chandelier or whatever, doesn't matter. Just make sure that they get it in there, okay? And make sure that it stays in there. That is our goal. We want to prevent the pregnancy. However they are comfortable, there is not one way to do this. This list could continue to go on and on and on. As people become more familiar and more comfortable with it, they put it in and it doesn't matter, okay? So laying down, big thing is to make sure that they are doing this pinching motion here so that it can close, it goes up the canal, and then when it gets back in here, it kind of opens back up again. So that's why they're allowed to still have sex, they don't need to take it out. Still use a tampon, they don't need to take it out. It's small, you usually don't even have any issues with this. So again, the other thing with this, outside of using our LARCs with those rings and the patches, we can have a quicker return to fertility, which is a big thing for some people. Maybe I don't want to be pregnant right now while I'm in IPAP, but maybe whenever I get out of phase 1 and I'm in phase 2, maybe I do. Maybe as soon as I get out of phase 2 and I go to my next duty station, maybe I do. So do you want to give me something that's long, that you have to implant or do any of that other stuff? It depends on what my timeline looks like, right? So all of that kind of stuff comes into play. So just make sure that you're listening to the patient on the exam, the same exact thing. If I tell you that someone is like, I have 2 kids and I don't want any more at all whatsoever, you have to listen to me because it's me that has to deal with the kid, not you, right? So you have to respect what it is that they're saying. And when someone is very young, or if someone has not had kids yet and they're telling you something that's a LARC, you're kind of more like, are you sure that you don't want to do this? Everyone doesn't want kids, okay? And we respect that everyone doesn't want kids. So you have to make sure that you're talking to the patient to see what their desires are for the exam. Make sure that you're reading the scenarios that you see to understand which contraceptive you should pick, okay? And the return to fertility is also going to be a big thing. What I wanted to tell y'all too is if you do those like AI tests, this one has so much extra information. I don't know if it will be worth your time to even put this into chat versus listening to what I'm telling you to focus on, because there's a whole bunch of stuff in here that I'm not going to be asking y'all about, okay? So take it if you want it. More so just repetition for this one. Your depot, this is your shot that we were giving, okay? So you have IM sub-Q formulation that you can give to your patients. Make sure that you're letting them know that they can go ahead and move around, but they should not massage. It's the same thing that we talked about before. If I'm giving you a depot, I'm expecting for it to slowly be released from that area that I gave you in. You start massaging it, bless you. Now you're pushing that area and changing the effectiveness of my drug, changing the duration that it should last. So they can move around, yes, massaging, they should not be doing that. They can potentially have bleeding. They should be taking that calcium because of the potential of the bone loss, okay? And then looking at this, when they should return next, usually we'll try to tell them every 3 months that they should return, but 11 to 13 weeks is when you can see that they will be back for their next injection to make sure that they're still covered. If you're changing from this shot to another contraceptive, you need to wait until that 3-month time period was going to wear off from when they had the shot, okay? And then they would start that contraceptive. So like, okay, you don't want to take the shot anymore. When was the last time you had the shot? Okay, here's the NuvaRing, or here's the combined oral contraceptive that I'm going to give you, started on this date, because you still have a month left, essentially, of the depot shot, right? It's still working, even though they're not physically taking something or putting something on their body. Delayed return to fertility, you can see that some people may not ovulate, which means that they will not be able to get pregnant for up to 2 years. There's some studies that say that it can be even longer. For your testing purposes, I will want you to remember the 2 years or the 24 months. And cautioning your patients who are older, right? We already said 35 is advanced maternal age. So if I have to now wait another 2 years, potentially, now the 2 years does not mean that that's what it takes for everyone, okay? We're saying it could go up to this, it could potentially go beyond this for some people. So if I'm already pushing the clock, right, because I'm over 35, don't give me something that's going to make it hard for me to become pregnant now, right? If I can be without ovulation for at least 2 years. Now I'm looking at 37. I'm like, a little bit. Okay, that's what we do when we get close. Start panicking. Your advantages. Again, when we look at this, just go over the things that are in bold. It's easy because I'm getting an injection. I don't have a lot of those estrogenic side effects that I was seeing with a lot of my other medications. I can decrease the pain and the amount of blood that people are having if they have heavy cycles. And I can decrease the amount of the risk of endometrial cancer whenever I'm looking at my depot. Disadvantages, that weight gain. Make sure that this says 24. I matched this with your lecture that you're going to have. So 24. Delayed return to fertility, again, as high as, and there were some studies that are even over that 2 years. Decrease in the BMD, the spotting, all of the things that we talked about, okay? So just continue to look at those. They're reiterated several times throughout this lecture. Here are your IUDs. So more so looking at this in our patients who have breast cancer, because when we're looking at some of our other medications, they can potentially increase the risk, right? Especially our combined oral contraceptives of that breast cancer, especially if somebody has active breast cancer or within that last 5 years. So again, I have an option for them. I have my Paragard, my Mirena, or my Skyla that I can use. This is important that they don't have any PID or pelvic inflammatory disease or any type of history of ectopic pregnancies, because those can also be increased with the insert when we insert an IUD in the patient. You see here that you can have some of these are specifically for heavy menstrual cycles. So when you look at your Mirena, this is why it says Mirena only. So for someone who has a lot of cramping, very heavy cycles, we can use this a lot. They're usually going to be anemic because they're bleeding so much from their cycles. So this has that FDA indication to be able to use your Mirena specifically for that. Long-term pregnancy protection, okay, so for at least 2 years, or for whatever reason they can't tolerate, don't want to have estrogen, you can use these for those. So can't tolerate or don't want to use those estrogen-containing products. And we say that if they've had at least one child for some of these IUDs. Again, that is a patient conversation, that is the patient's choice. As long as you document whatever they said. What if I told you I don't want any children? Are you going to tell me that I can't have an IUD? You can't tell me that because I'm telling you that I need protection, right? So again, for you to protect yourselves, you just make sure that you document. Patients say they're not interested in children and they ask for an IUD. No, they don't have any, and I know that they're only 20. Like, I'm doing my job. And they said no. Okay, they said they want this, and I'm going to document it. That is how you protect yourself. Document, document, document. You can educate them and talk to them about it. Ultimately, it's up to them. Your job is to educate them. Your advantages, you see that they're reversible, long-term use for these. But you also see that you have your copper IUD for people who are like, I don't want hormones, I want to stay away from hormones. And then you have your progestin IUD, which is helpful with decreasing that bleeding that the patients have, the cramping. And then we specifically had our Mirena for that. And then all of the disadvantages kind of make sense if you look at them, because if I have some type of abnormally shaped uterus or any type of trauma that is there, it's going to make it harder for that implant to stay. And you don't want to cause more damage while you're trying to place the IUD. So you have to be very, very careful whenever you're looking at using these. Preferred if somebody is monogamous and in a monogamous relationship, because you don't want the lack of having to take a contraceptive make them forget about the STD risk, right? So if they're not going to use condoms, but they're like, well, at least I'm not having a baby. Like, you could also get stuck with other things that you can have for the rest of your life too. So you still have to be careful, okay? So this is also, again, that is why you see that preference. But your job is to just counsel those patients to make sure that they understand, hey, you still need to use protection against STDs if you're not in a monogamous relationship. The copper IUDs, which is why we don't like them, yes, they last for a very, very long time. And yes, they don't have hormones in them, which is also very good. But you see that it could potentially increase how much I bleed It could also increase the amount of cramping I have. So copper, cramping, copper causes more bleeding, okay? Copper is also the one that lasts the longest. It's in there for 10 years, if up to 10 years if someone wants to take it out before you can. Your progestin IUD, you see that you can have some very irregular cycles, and over time those decrease, they get very light, or you'll see where some people say they don't have their menses at all, okay, once they have the IUD in for a longer period of time. Looking at our copper or our Paragard, the only one that we have right now, essentially what's happening is those ions from the IUD are stopping the motility of the sperm, and therefore they're not going to be able to go where they need to go. And then you don't have the fertilization of the egg. Again, I told you already the 10 years, your contraindications, all right, if there's any type of undiagnosed vaginal bleeding, any type of vaginal abnormalities, if somebody is allergic to copper, don't give them a copper IUD. If they're already pregnant, can't do anything there, right? And then if you see here where it says women with current or recent STDs, or if they're at risk of STDs because they are not using protection, we also don't want to use this because this can also cause a lot of other issues that we would then have to dig deep for to figure out what is the cause. Now I have to go and take out the IUD, so on and so forth. So you want them to be in a stable situation. Remember, this one was also the one that gave us that 100% efficacy when we were talking about the emergency contraceptives. So very, very good for that use as well. Immediate return to fertility after the removal, because again, we don't have any hormones there that we're waiting to rebalance. So if they did want to become pregnant after that, they could. Your levonorgestrel, which is progestin, you have Mirena, Liletta, Kylena, and Skyla. When you're looking at this mechanism, essentially the same exact thing, right? Placed in the uterus, therefore I can't have that implantation happen with that egg in the sperm once it is fertilized. And then again, making the vagina inhabitable, okay? Contraindications look the same as any of those other things that we were talking about, any of our other devices like our copper device that we were talking about. Your products that you have, I just want you to pay attention to the different names, right, that we have, and then also the duration, because the duration varies depending on which one you're giving them. So when you're looking at your Mirena, 5 years, this one is the one that will help us with that, the bleeding, the abnormal heavy bleeding, right? We said that on the previous slide. But what you see here is for the bleeding control, if I'm just using it for that, right, for the heavy cycles, if I'm just using it for that, I have 5 years of where I'm expecting for it to work. If I'm using it to avoid contraception, right, so if I'm using it because I don't want to become pregnant, I have up to 8 years to keep that in, okay? So the indication changes how long it can stay in my body. Then you have your Liletta, 8 years, your Skyla, 3 years, only using this for contraceptive, same thing with your Liletta, only for contraceptive, and your Kylena, 5 years, only for contraceptive, okay? So your Mirena, M and M, right? Menorrhagia, Mirena, 5 years, 8 years contraceptive, 8 years contraceptive for your Liletta, Skyla, 3, Kylena, 5, and these are also only contraceptive purposes. When you look at your Implanon or Nexplanon, this was the one that we talked about that was like the matchstick. They're going to have that local anesthesia. They put the rod in the upper arm. Essentially what happens is it slowly releases your etonestradiol, and that is going to again act the same way that we talked about with inhibiting the sperm, making it not be able to be able to move in an inhabitable vagina, so it's not an ideal place for the sperm to be. You also see that we also have the efficacy for up to 3 years. So you do have where several people will get these replaced, you know, over that 3-year time frame. A little bit uncomfortable. Most people say it's quick. It doesn't really hurt that bad. And I have heard stories where people, their body rejects it. That's when you hear a lot more of those complaints. And be ready to hear that with any of our LARCs. You can always have somebody's body say, that's not supposed to be here, and it tries to reject it. When you look at the efficacy, again, with the weight, anytime we're looking at these hormones, understand that the more overweight someone is, the more likely the efficacy is going to go down. Your adverse effects, very similar to all of the other things that we looked at, except for the rod potentially breaking. These are those complications that we would have. redness at the site because they're going to have to inject, right, and put that that Nexplanon inside of someone. And then the return to fertility, it will be up to 6 weeks once they remove it. So again, a lot of your patients will tell you if something is wrong because they feel it or they will see it. And sometimes it's cause for removal, sometimes it's not. Sometimes you will go to remove it and you're having to figure out where it went because it's not where you placed it, but it was still working. Adverse effects, again, very similar things. Kind of in my mind, I associate this with the patch for whatever reason, and I don't know why. But I'm looking at the side effects of the breast pain and tenderness. How I said, like, don't give it to or don't place it on their breast. The irregular menses, the swelling of their lower legs. Good options. These also don't last the entire time that someone has the IUD in as well, or the implant in. Your rare, the change in the vaginal discharge, abdominal, GI issues, those aren't very common, so I'm not going to ask you about that. But again, looking at those thromboembolic events and the hypertension as a potential, make sure that you know that they're there. Your glucose intolerance, what that means is that you have a higher than normal level of glucose, and their body is not doing what it is supposed to do with the glucose as far as storing it. So when you look at your the side effects for these, usually within the first 6 weeks or whenever you're going to see this happening. Return to facility, this is just telling you when most of the time after someone is taking a contraceptive, specifically looking at your combined oral contraceptives, you'll see that it can be immediate, but up to a 2-month delay for some of your patients. We do recommend that if they are trying to become pregnant, that they have at least 3 cycles without any of that medication in their body. At that time, give them folic acid, everything to make their body more ready for a pregnancy. So giving them those prenatal vitamins whenever we're trying to allow their body that washout period from the hormone is good. Your implant, remember that you have about 6 weeks, and then your depot, remember to change this to 24. I wanted this to match your women's health, and it could potentially be even longer. But exam purposes, if you see this one, it would say 24. 24, 24, 24. All right, memory jog slides. This is where I would focus a lot of my time after you have gone through the slides, okay? Don't just go to the memory jog. I will never tell you to just go to a memory jog. This is the good summary for you to say, like, okay, where should I go back to? Where am I gonna like try to make sure I hone in and zoom in on these topics, okay? This was, again, giving you that brief, kind of the words of that super busy slide about when they could use a contraceptive versus when to not use a contraceptive if they were postpartum. So that's what this is looking at. Your emergency contraceptives are here, telling you the efficacy, all of the things. It copied it. Did it twice. And then your IUDs, all of those are, again, here telling you the big things about them, when you can actually use them versus not. Don't forget your Mirena in here. And then this was looking at your sensitivities. Again, this is the one that I want you to focus on, that is a summary. So whenever we go back through the slides where it has like the estrogen sensitivity, estrogen deficiency, those charts, don't worry about those. I'm not focusing on those. I want you to remember what it said on the estrogen sensitivity, progestin sensitivity, androgenic sensitivity slide. Because there are some that say something different, because there's more things that I'm not going into with you guys that you will potentially see later, okay? So don't use, is that a baby? Do you hear something? Maybe I just hear kids. I thought I heard something too, but maybe it wasn't a baby. So when you see these for the estrogens and progestins, don't worry about these. FYI, these, I don't want you to use these. I want you to focus on like this and what it's telling you to do if you see these symptoms, okay? And this is what it's telling you to do when you see those symptoms, okay? And then the very last of your memory jog, sorry, look away if you get dizzy. The very last, this was, again, giving you a quick summary, right, without all of the words. I went through and just kind of wrote everything out for you. Your estrogens, the key features that you needed to from that plus and minus chart. I made another chart for you that just has words that are simplified and a lot smaller. Because I like, remember she's basic. I know y'all been gone for a little while. Remember I'm basic whenever you're looking at a lot of these things. And then your pops and what we are looking for here. When you look at that sensitivity chart, make sure that you don't try to say, oh, this has no estrogen at all. I'm going to pick this. If I'm telling you to pick low estrogen, I don't mean no estrogen, okay? A pop is not better than a combined oral contraceptive in any circumstance, unless they have those high risk features, okay? All right, that took longer than I expected. Well, not really, because we got delayed. So, all of this other stuff is just FYI. Don't even waste your time with those things, okay? Dare I? Let's go. We're done for the day. It's only 10 minutes. All right, so I don't think I have you guys again until next week. So on Monday, I have y'all tomorrow? No. Okay. You sick of seeing me? I'm sick of seeing you too. That's why I'm going next door. I'm going next door where I'm wanted. Okay? But what we're going to do is on Monday, we're going to do probably 2 lectures. And they're the shorter lectures, so steroids, and I think there's a pregnancy one that we're going to do. And then I'm just going to make it to where I'm not leaving us hanging with like having to split a lecture on 2 days, and then probably Tuesday we'll be done. I will see what happens whenever we get to that day. Just make sure that you all have all of the slides. I will also try to figure out how to get that fixed so that this doesn't happen in the second block. I'm going to release some of the slides for the second block now. In the pain portion of this, you will have a guest lecturer. She's the pain doc from Nancy, so she specializes, she's a pharmacist, and she specializes in only pain management, so that's all that she does. So how we have the ID doc come in, we will have her come in, and she's going to teach a lot of that for us, okay? See y'all later. Good luck on your exams tomorrow. I'm here for questions if y'all have questions.